Hello, everyone. My name is David Armstrong. I'm the Director of the Health Workforce Technical Assistance Center. Welcome to our webinar series. This event is entitled Advancing Behavioral Health Workforce Research and Policy. Let me go ahead and introduce you to today's presenters, the star of the show, per se. Today, we're joined by Brianna Lombardi, who's the Director of the UNC Behavioral Health Workforce Research Center. And she is located at the Cecil G. Sheps Health Services Research Center at the University of North Carolina at Chapel Hill. Also, we're joined by Lisa Zerden, the Deputy Director of the Behavioral Health Workforce Research Center located at the University of North Carolina. With that said, I'm going to go ahead and stop sharing my screen and, let y'all take it over.
All right. Y'all see my screen?
Yes.
Great. Hey, y'all. I'm Brianna Lombardi. I'm so happy to be with you today. My pronouns are she, her. In addition to being the director of the Behavioral Health Workforce Research Center, I'm also the deputy director of the Carolina Health Workforce Research Center. I'm a social worker by training and happy to be here with you and with Dr. Zerden. Do you want to say hello, Dr. Zerden?
Hello, I'm Lisa Zerden. I'm really happy to be here as well. We have been recipients of some of the other workforce research centers as PIs, and so we're very honored and grateful to now have the opportunity to lead the Behavioral Health Workforce Research Center. I'm also a social worker by training, but I focus more on policy and the macro aspect of health services and delivery.
We're excited to talk today kind of generally about how we see the world, how we think about health workforce research specifically for the behavioral health workforce. We'll share with you some of the projects that we've done in the past, as well as where we think we're going. Just wanted to highlight our funders. As Lisa mentioned, we've been funded by the Carolina Health Workforce Research Center here. And obviously, we're currently funded by the Behavioral Health Workforce Research Center.
So just to give everyone some context, we wanted to just express our appreciation for the other workforce research centers who have helped lead this work. We are lucky to be at UNC Chapel Hill, where we have worked with Dr. Erin Freyer, who has helped us think about our work and behavioral health as a workforce. And so we were really excited earlier this summer when we found out we were awarded the Behavioral Health Workforce Research Center, which was formerly at the University of Michigan. In this responsibility for this cooperative agreement with HRSA and SAMHSA, we are responsible for completing 8 research projects per year related to the behavioral health workforce. And as we will talk about in a minute, the behavioral health workforce is very diverse and there are lots of nuances to it. And so 8 projects is a lot for one center, but it's also because of the variety and the spectrum of behavioral health providers. And then I have just given you some other examples of the other centers. Our priority is to think about the behavioral health well-being in the US and how do we strengthen the workforce who can address these issues. We have 3 priorities. The first is to evaluate these disparities, to really think about data and data-driven research so we can help inform policy, thinking about the workforce composition, the needs and sufficiency. So where are folks and are they distributed or maldistributed in appropriate places? And then thinking about service delivery and setting, which we'll spend some time talking about different ways that behavioral health service delivery actually occurs in communities and in the real world. This is a picture of our team and our organization. We are really fortunate to be partnered and to have the opportunity to work with several other researchers across our campus. We represent social work, public health, psychiatry, family medicine, stats methods. So we really have a diverse behavioral health workforce team. And we're also lucky to partner with consortium members who reflect behavioral health service delivery and needs on a national level from a consumer perspective, payment perspective, and practitioners as well. We're going to highlight some of the projects that we were funded to do this year. We're not going to have an opportunity to talk about all of these. And because we're in the middle of our year, we don't have all of these finished, but we can give you some teasers and some preliminary findings. But just to give you a sense, we wanted you to see the spectrum and variety in the kinds of projects that we were funded to do. Looking at the harm reduction workforce, for example, in terms of who is providing harm reduction community-based services and how are behavioral health issues addressed. Looking at behavioral health providers in areas of deprivation, which we'll talk more about later. We have 2 projects related to peers, looking at the child mental health workforce. So you can see the variety. And if you have specific questions about any of these, we can always answer them at the end or talk to you offline if there's a particular project that is of interest to you. I don't think that we need to kind of belabor this point because you probably wouldn't be on the call if you didn't already have an interest in behavioral health. But we know that across every strata, across the life course, behavioral health issues are really of paramount critical concern. We have seen this exacerbated by COVID. But what I want to also point out is not only are people affected by behavioral health crises, the workers themselves are experiencing behavioral health crises, the health workforce, the behavioral health workforce. And so that's something for us to grapple with as well, not just the consumers of care, but also the workforce, and how do we sustain them to do this care given the stresses that they're under. Here you can see how COVID has exacerbated behavioral health needs in the United States. You can look at the graph on my left, where you look at symptoms of anxiety and depression. You can see that in the height of the pandemic, December 2020, rates of anxiety and depression were 4 to 5 times higher than baseline. And you can see the combination of that was also much, much worse. We also know that in April of 2020 to 21, we had more overdose deaths than we've ever had in our country. This reached over 100,000. It was about 106,000 in a 1-year period. So you can see how COVID has really exacerbated behavioral health conditions. Although what we would like to point out to you is that COVID did not cause or kind of create behavioral health issues. It just shone a spotlight on these issues themselves.
Yeah, and that's what we wanted to talk to you a little bit next, is thinking about that this is the behavioral health crisis, although has a light shown on it, that this has been an ongoing unfortunate trend that we've been facing. And I think folks who are on the call who've done behavioral health work prior to the pandemic or have been clinicians for many years have seen this kind of worsening trend within the behavioral health field. This is findings from the 2023 YRBS looking at rates of depression, feelings of sadness, or increased hopelessness amongst our youth, with more than half of female identified participants reporting that they were experiencing feelings of depression, and similarly looking across the last 10 years of an increasing rate. And we also see this with folks with serious mental illness. This is from SAMHSA's National Survey of Drug Use and Health, looking at the rates of serious mental illness across age cohorts has been increasing over the last 10 to 12 years. And unfortunately, at the same time we've seen these increasing rates of behavioral health need, we have had stagnant rates of behavioral health service delivery. And so when we think about folks, what proportion of folks who need mental health services or are interested in mental health services, we're hanging around 50%. So about 50% of folks who are interested, and the numbers vary based on diagnosis and age, but you can see in the trends over the last 12 years that we've haven't made much progress in increasing the rate of behavioral health service delivery. And we know for folks with substance use disorders that this is even worse. And so that it goes from 0 to 10, and that means less than 10% across age cohorts are gaining access to treatment for addiction. So certainly not only an issue when we're thinking about mental health, but also when we're thinking about folks with substance use disorder as well. So when we look at these numbers and we go out in communities and talk with folks, we've been having this discussion is what is the common suggestion to address this crisis, this significant behavioral health crisis, this worsening behavioral health crisis, both in symptoms and in service delivery.
So the common suggestion is to add more, right? We need more people in order to meet this need. We wanted to show you a HPSA for our health professions shortage area for mental health, the most recent data from 2022. And you can just see how many counties in the United States are without a mental health provider. You can see the lighter blue colors might seem, like they're doing better or better than what the other options are. But we need to take into account that might mean there's just perhaps one psychiatrist in that county. It also doesn't reflect that provider is perhaps not taking new patients. Perhaps they don't take the insurance that someone has. And so HPSAs give us kind of a broad overview, but they really don't tell the whole story. And they also don't tell the whole story that more is what we need. Just to give you some data on what this means, we can think about psychiatrists, which is often the workforce that is used to kind of think about these things most broadly. We know that HRSA estimates that in 2017, there was approximately 33,500 adult psychiatrists, except we know that in the next 7 or so years, we're going to be seeing a decrease in the supply of physicians who are going into psychiatry. We will have an increase in child and adolescent psychiatrists, but you'll see that the demand doesn't match the projections. And so this is a problem when we think about what are the issues and how are we going to kind of fill that. So demand and supply is not aligned. Here you can see as well for other types of behavioral health workforce shortages, we know that rurality and geography play a really important role. Andrilla and colleagues have done this work looking at rurality, and you can see per 100,000 K what the differences are per behavioral health provider in metro and rural areas. And you can see those differences there, which are significant. We also know not only are there behavioral health workforce differences in type, but there's also differences in the type of facilities or settings that offer behavioral health services. So we know that rural counties lack mental health outpatient facilities that accept Medicaid or offer specialty mental health services. And so this is a problem for folks who are already marginalized or have more vulnerabilities, who may be relying on Medicaid or public mental health service system, which isn't adequate to meet all of their needs.
And so we just need more, right? Is that the solution? And we're not trying to be facetious, because we do know that there is a behavioral health workforce shortage, but we're interested in really pushing the envelope to think, would that be enough to increase access to care, behavioral health care for folks who need it in our communities? And here's two kind of zoomed into states where we're thinking about health profession shortage areas. And you can see in Massachusetts that only one of their counties are in a true shortage, but I don't think anyone in the state of Massachusetts would say we have enough behavioral health providers who are there. And similarly in North Carolina, this kind of box in the middle is where Lisa and I are sitting in Orange County, and certainly no one here would say we have enough behavioral health. So even when we are looking at some of the distributions of the shortages, we know that folks aren't getting access to care, and it's not reflecting the lived experiences. And this is something that I've been inspired by Aaron Freyer, is really thinking about that the national shortage narrative detracts from a focus on redesigning the system. If all we're doing is thinking about that we don't have enough, we're not thinking about if we have enough of the folks with the right training who are distributed in the right areas that are reflective of the communities that they serve, and that are positioned in settings to be where the places where folks need care. And so although we don't want to minimize that there is a behavioral health workforce shortage, we're concerned that this kind of singular focus will detract from actually moving the needle on what we all are really interested in, which is to increase access to behavioral health care for those who need it. And so we like to look at the 5 A's, and this is commonly looked at within rural health research, really thinking that access to behavioral health care is more than just the demand compared to supply. It's more than just the sheer numbers of behavioral health providers. But this is so much of what workforce research is focused on, is how many we have and how many we need.
And obviously that's not adequate. So when we look at this framework from Pachansky and Thomas, we can see that there's other dimensions that we have to consider. So it's not just about shortage and availability, but really thinking about accessibility, as we mentioned, the maldistribution of where folks are located. And we're going to talk to you about one of our studies that looks at this by behavioral health provider type. Thinking about accommodation, knowing how to connect with service systems. We know that several studies have shown that people don't know where to receive care. Again, if you think about linguistic, cultural barriers, insurance barriers, this just makes it very difficult for folks to know how to access those services. There are different types of health workforces who are helping to make those accommodations through navigation and coordination, but we know that they're not distributed equally as well. Stigma is a huge barrier to care as well. And so we know that the acceptability of folks seeking services for their behavioral health issue is not always there. And when we think about this, we also have to think about stigma for different types of mental health issues and diseases. And sometimes we hear behavioral health being separated or siloed into mental health and substance abuse. And we like to think about those comprehensively so that we're not creating a stigma about worse, better, different types of patient populations. Again, thinking about what's appropriate in a community, what's going to be something that community members are going to want to access. And then we've talked just briefly about affordability and just knowing what a barrier that is to care if you don't have access. And we'll talk about a study that looks at Medicaid expansion as one example.
And so when we're really thinking about, a behavioral health workforce, when we think about how do we advance behavioral health workforce research and policy, we really are thinking about beyond supply and what other aspects of workforce policy can be impacted to increase access to behavioral health services. So not only thinking of supply and distribution, but what are the training and education programs? How does scope of practice influences who's allowed to do what in which state? How that interacts with licensure and certifications and payment, and then also thinking about the facilities and services on a continuum across different settings and different communities. So now we're going to talk to you about a couple studies that kind of help you think about how we think about behavioral health workforce research, and Lisa's going to kick it off with one next.
So this is a study of how we have incentivized behavioral health providers through workforce education and training. This study actually predated our becoming the directors of the Behavioral Health Workforce Research Center, but it's really what helped us think differently about our work. So just as an example, we wanted to talk about the BWET funding mechanism, the Behavioral Health Workforce Education and Training Grant, which came out of HRSA in 2014. This was funding that really came after the Sandy Hook shooting and just recognizing that there was a very pervasive mental health crisis happening for transitional age youth, 18 to 25. And so they really invested in wanting to expand the behavioral health workforce initially through social work programs. And so what we wanted to look at was, of the schools who received this funding, how are they aligned with at the time, the rapidly advancing expansion of Medicaid across states? If states are expanding access to behavioral health and preventative services, do they have the workforce who is available to meet those needs? Because it didn't seem like that match, and I'll show you a map. Yep. So when you look at this map, you can see states that expanded Medicaid and the number of BWET funded schools. I'm sorry that the key didn't pop up here, but I can just tell you that the dark gray states, looking at Utah, for example, those are states that had expanded Medicaid, but did not have the behavioral health workforce training in place. When you look at the light gray, like Texas, you can see that there's no Medicaid expansion, but they did have schools that received the BWET mechanism. When you're looking at the Black states, those have neither. They don't have Medicaid expansion and they didn't have the BWET mechanism. The white states, which is the largest, so that's the good news, about 49% of them had both Medicaid expansion to expand behavioral health access, and they had the training program. So this is just something for us to think about when we contextualize it with North Carolina, for example. You can see that recently in the past 2 months, North Carolina has expanded Medicaid. So this is somewhat dated, but at the time, North Carolina had not expanded Medicaid, and our state received 5 BWET mechanisms, meaning that there was 5 different institutions who had received this training grant. So you had workers who wanted to do the work, but they didn't necessarily have the placements and the jobs post-graduation to be able to provide this type of care. So this is one example of a maldistribution between or misalignment between Medicaid expansion and behavioral health workforce initiatives and mechanisms to expand the workforce.
And another goal of BWET is to train social workers, but now the BWET includes a broader subset of behavioral health workers to be integrated into physical health settings or delivering integrated behavioral health care. And so some of our early work was also really thinking about what is supporting behavioral health workers integrating into behavioral health? And something that I'm sure all of you have heard and that we similarly heard is that there's not a great way to pay for it. But at the same time, in 2018, we know that the psychiatric collaborative care management codes and behavioral health integration codes became available to try to find ways to support the delivery of COCM and behavioral health integration more broadly. To deliver integrated behavioral health. So these are findings from a study that we did. It's under review, hopefully will be out soon, thinking about for federally qualified health centers, if they were using the COCM codes or not, and how the COCM codes were if they felt that they were supportive of the integrated behavioral health model that they were interested in delivering at their community health center. And so we did a survey of 10 states of federally qualified health centers in those 10 states, 46 responded. And unfortunately, of the FQHCs that did respond, the vast majority said that they were not using COCM to support the model. They were not using behavioral health integration to support the model. But even more concerningly is many were not even aware that there was these mechanisms to support team-based behavioral health care. Then we talked with them. So after we did the survey, we asked folks if they'd be interested in doing an interview to talk to us a little bit more. And we coded the interviews to identify kind of what is keeping folks from using the COCM and the behavioral health integration codes. And so some folks said just the model of COCM was difficult. And so they weren't going to be using the codes because that COCM model wasn't a fit for them and what they were delivering. And so they said, it's very difficult to make it work, and not even from a reimbursement perspective, it's difficult to find the humans and the whole team that could understand it and really make it successful. So this was an also really interesting finding, is because of the behavioral health workforce shortage of the specific types of behavioral health workers they were looking for, they were not able to make COCM work in their clinic. Another kind of theme that we heard was the COCM codes are not self-sustaining. So this individual said it becomes a cost-benefit analysis of how much additional money does it bring in for us to deploy these codes for these 15-minute chunks of time we use here and there. At a certain point, we kind of just go, it's not worth it. And this is something we heard often, that the codes were not enough to employ what many folks were trying to employ, which was licensed clinical behavioral health workers, so licensed psychologists or licensed clinical social workers. I know COCM that does not require a licensed provider to deliver care, but that is what many FQHCs were interested in using. And similarly, FQHCs, because they were not using COCM, they were looking for alternative ways to fund behavioral health time. And so this person was describing that the cost of having someone sit there or having a social worker sit there to be available in a COCM model when someone might do a warm handoff if they screen positive for a behavioral health need, that they didn't have ways to do that. And so in many times they were having a licensed clinical social worker or a licensed psychologist also delivering one-to-one therapy. And so because they were delivering one-to-one therapy, in order to pay, they were also not available. So really thinking again, how both, certainly a workforce shortage interacted with the use of COCM, but also who is allowed to bill for what, and how some providers who are able to bill were more interest, CHCs are more interested in supporting those folks in hiring. So interacting, and again, in the shortage, as well as available clinicians. We'll tell you about one more that's actually, and so these are all past studies that Lisa and I have completed through the Carolina Health Workforce Research Center or through the University of Michigan's Behavioral Health Workforce Research Center. And the most, one of the studies that we're going to talk about next is one of our year one projects. And we were really interested in understanding the distribution of behavioral health provider type, not just by rurality, but really thinking about areas of need and areas of deprivation. This is kind of coming out of the work that was done early in the pandemic that was particularly noting that there were certain communities that were at greater risk for COVID exposure and harm, and really kind of the highlighting that, certain communities, particularly ones that are minoritized or marginalized, were having worse health outcomes. And so we were really interested in looking at distribution of care in communities of high need. So we use the Area Deprivation Index, which was originally developed by her son, is now at the University of Wisconsin, to understand kind of and classify communities with high need. The ADI is one of other measures that can be used. So, for example, the Social Vulnerability Index is another one that's out there. The ADI is at the block group level, so a pretty fine-tuned level of geography. And it includes 17 indicators of economic, education, and a community social need. So the percent with a high school diploma, the median home value, the percent of occupied housing, and unoccupied housing. And so we looked at 3 workforces using the MPPS. And so we can talk about data sources later, which is the internal battle that Lisa and I do with the behavioral health workforce research. So we use the National Plan and Provider Enumeration System. This is the MPPS. For folks who are eligible to bill CMS or work in a setting that's billing to CMS, are required to obtain an MPI. An MPI is self-reported though, and folks identify their own taxonomy as well as their practice address. So we took those practice addresses and we geocoded them we just used the individual file, not the facility file in the MPPS, and looked across 3 common behavioral health workforces at the professional or graduate level: counselors, psychologists, and social workers. And you can see here we had about 840,000 behavioral health workers, and the majority of them were counselors. So more than 50% of the data source was counselors. And so after we geocoded, we placed the addresses into block groups, looking at block groups with the Area Deprivation Index. And you can imagine what we saw was this interesting trend where at 1 is areas with the lowest need, and 10 is areas with the highest need. So we deciled the ADI. And you can see an interesting trend that in areas with the lowest need or the most advantaged had more behavioral health workers per 100,000 than the lowest areas in need. But there was an interesting pop here at the end. But on average, there were more behavioral health workers per the population in areas of low need. And when we lifted the hood, we saw trends by behavioral health provider type. So you can see social workers and psychologists. Social workers, there were more social workers in areas of low need than there were in areas of high need. And similarly with psychologists, though, more psychologists in areas of low need than high need, but there wasn't that pop. But when we lifted the hood, we saw counselors across the board being more likely to be in areas of high need than areas of low need. And this really struck us because, as you all are probably aware, licensed mental health counselors and addiction counselors are not independently reimbursable by CMS, although they will be, or the LMHCs will be in 2024. And so it's interesting to us that in areas of higher need, maybe those who would best be served by Medicaid or Medicare, they are not having access to the behavioral health workforce as areas of low need who might be privately insured. We also wanted to take this a step farther and look at it by rurality, and it's just what you would expect, was that there's an interaction between rurality and area of need, where if it's not rural, we're using the 4 Federal Office of Rural Health Policy definition of rural. In areas that are not rural, there are more behavioral health workers in areas of low need than areas of high need. But within the rural, we've kind of had more of a flat line between the areas of high need and areas of low need. But on average, about half of the behavioral health workers per population as compared to in not rural settings. So we're interested in kind of continuing to push this forward to really thinking about not just a shortage, but a maldistribution, and not just a maldistribution by rural settings, but also a maldistribution in maybe some of the communities that have higher social needs, and really thinking about who is the workforce that is there and is available to serve that group of folks. Lisa?
Thank you. So it's very easy when you're talking about behavioral health issues, behavioral health workforce issues, to really get kind of depressed, right? It's just, there's just so much need, there's so much to do. And so what Brianna and I want to do as we get towards the middle of our presentation is really think about ways to kind of still have hope and recognize that we still have a lot of promising practices that can advance the behavioral health workforce. Despite these issues, despite some of these problems that we're going to point out, there's still so much we can do. And so there's 3 takeaway promising like action items or hope items we want you to think about. The first is to think about teams. There is just no reason to go it alone. We want to think about setting and not being constrained to clinical setting. And then we want to think about professional pathways and personal trajectories to really help advance the behavioral health workforce. We'll give you some examples of that.
So with Don't Go It Alone, the behavioral health workforce is broad. It incorporates what most commonly is considered or thought about psychiatrists, but includes a range of both professional and non-licensed clinicians, but also clinicians that we might not think are incorporated, like occupational therapists. And so certainly we have a wide range of behavioral health workforce that we can consider to fill this need. And, as always, there is some tension within any guild about, their role and wanting to make sure that they are. Unfortunately, we are at such a crisis where we need all of the providers, all of the clinicians, all of the guilds in order to help address this crisis. And so it's not a time now to really think about, kind of how to protect your own guild, but also how do we think about how we can work together to address this behavioral health crisis. But we think about that there are big data challenges, and if we want to think big and think about the behavioral health workforce as this broad group of clinicians, we have major data challenges because most data sources are siloed to professions. So we can see how many psychiatrists and how many psych MPs and how many psych PAs, how many social workers, how many psychologists, but it's hard for us to see what is the composition of those different workforces working together, or that might be filling the same role in different settings. Behavioral health workforce spans sectors. So administrative data is just focused on one sector. And we know that the behavioral health workforce works in justice, works in health settings, works in schools, works in communities. And so many of our traditional data sources don't cross-sect all of the places that behavioral health workers might be. And, the behavioral health workforce includes a broad set of unlicensed or paraprofessionals who cannot be tracked via traditional licensure or graduate data. And that this is a huge and important part of the workforce. So really thinking about trying to understand how many folks who are working in this field who are playing a large role can be difficult because they don't have licensure roles like some of the other workforces do.
And just to point out one other thing regarding the different data challenges, not only do we not have a way to enumerate this all together holistically, but really state by state variations of how behavioral health providers are enumerated and classified. So you even have variation among states and you don't have national broad databases. One of the ways that we wanted to talk about not going it alone is thinking about expanding team-based care for behavioral health. And one example that we wanted to talk to you about is looking at the DEA waivered prescribers for medication for opioid use disorder. We know that this is the most effective treatment we have for opioid use disorder, and we know that it is becoming increasingly common in primary care settings. And so given the numbers and the overdose deaths and the rates of opioid use disorder that I mentioned, you can see that this is something that has to expand as well. And so what we wanted to do in one of our most recent studies that we finished with the Carolina Health Workforce Research Center was to think about this team composition. And so we looked at waivered prescribers. We know that with the X waiver, in the middle of the study, the law had changed. And so you no longer have to have that particular kind of waiver, which is good for access. But at the time, we were looking at the SAMHSA DEA waivered file, and you can see differences based on those providers in terms of who is co-located with a behavioral health provider. And so we, again, use the NPPES data to really map those on together. And you can see that there were overall, when we're looking at NPs, PAs, and MDs, about 48% were co-located with a behavioral health clinician, although by DEA waiver type, there was differences. So here you can see MDs on the top map, and then you can see nurse practitioners on the bottom map. Again, you have ranging of co-location from 20 to 70 or 80%, but different states have different levels of co-location, and that speaks to different scope of practice, different reimbursement, different locations of school programs that have, might be producing more NPs or MDs in particular states. And so co-location is really a very crude measure of integration. We're aware of that, but it's just a way for us to think about who and how our teams working together to address something like opioid use disorder. And we have a policy brief on this. So if you're interested, I think that's at the end for references.
This is you, but related to this is thinking about the being constrained by setting or delivery system. Is so thinking about, behavioral health occurs across many types of settings. And we just gave you an example of one of DEA waiver prescribers that are delivering MOUD. But they're in many other types of settings too, like schools or justice involved settings, community health centers, harm reduction, community-based organizations, and dental, which Lisa will share a little bit with you about.
When we think about behavioral health integration, we've really moved the needle on behavioral health and physical health. And there's also been a lot of traction looking at physical health and oral health, but really behavioral health has been missing from that trifecta. And so one way to think about behavioral health in an out-of-the-box setting is to think about our role and placement in behavioral health, looking at behavioral health issues. FQHCs do a really nice job, a better job at integrating all three of these different types of health, looking more holistically at a person. But traditionally, behavioral health and oral health are really quite fractured and siloed. Although we know there is so much connection between substance use and the impact it has on mouth, gums, and teeth, thinking about different types of cancers, different types of tooth decay. We know oral health is impacted by mental health. Mental health is impacted by oral health. For example, if you are having a mental health crisis and you're not able to maybe take care of certain activities of daily living, you're going to have, you're more disposed to different types of gum and oral disease. So we see this happening, but we don't have a good way of tracking how oral health, mental health, and substance use are working together. We did a quick assessment on different dental education programs in the country. And of the accredited programs, 13 out of 68 have a behavioral health or social needs component to their programs. And so when we think about training oral health providers, both dentists, dental hygienists, we can think about getting them to think about these issues. A lot of trauma and different types of behavioral health issues, maybe an eating disorder, for example, can manifest in the mouth. We don't always think about the connection and team-based setting, team-based collaboration that happens in these oral health settings. And so we're starting to research this and talk a little bit more about this from an education pipeline, and then thinking about practices post-graduation.
And really, there was I see a question in the chat thinking about, does this account for tele-behavioral health? No, it doesn't. And tele-behavioral health is going to change the game. and something that is really exciting, but also something that really we'll have to take into account when we're thinking about the distribution of the behavioral health workforce, what it means for telebehavioral health. And so obviously during the pandemic, telebehavioral health exploded. Folks were able to be reimbursed and not have to go to a site, that they were able to receive care in their own home, and providers were able to deliver care from their own home. And so telebehavioral health certainly exploded. And unlike some of the other health backgrounds, telebehavioral health remains high. So the amount of behavioral health care that's being delivered via tele is high. On the left, you can see from Kaiser Family Foundation, the percent of outpatient visits that are for mental health or substance use disorders in August of 2021 was still around 36%. And then similarly on the right from the McKinsey Institute is thinking about the share of telehealth for outpatient office visit claims. In February of 2021, psychiatry still being at about 50% and much higher than, and substance use being about 30% and still being much higher than the other kind of health physician backgrounds. So we know telebehavioral health is very excitedly here to stay. You know, there are some complications. We know folks in rural areas might be less likely to access some of the telebehavioral health because of the concern about audio only versus video-based services. And we know that there might be some cultural differences in who wants to receive care. But broadly, telebehavioral health hopefully can expand. We're doing a study this year as well, looking at the delivery of telebehavioral health in federally qualified health centers. And we looked at the proportion of the proportion of all mental health visits that were delivered by tele. And you can see kind of one of our initial images on the screen that it varies significantly. So in some states, about 11% of all mental health care is delivered via tele. In some states, it's as high as 74% of all mental health care. So huge state variation, but really trying to understand what is it about these certain states that is supporting telebehavioral health? What can we learn about how some of the federally qualified health centers have really been able to do a large share of their care in this way? And what ways we can support the workforce. So what we also heard in one of our initial studies with federally qualified health centers is that clinicians want the flexibility of telebehavioral health, and not thinking about how this could be a way to also support the workforce that is delivering care. So kind of going into that is like, you know, not being constrained by setting, not being constrained by just one workforce, but also thinking across the personal and professional trajectories is important. So often we only think about the front door. How do we get people into the workforce? And we think a lot less about how to support folks across the trajectory of their career. So really thinking about what are ways that we can support both mid-career and late career folks. How can we support them in possibly being supervisors or clinical trainers, focusing on retention? We're doing a study this year that's looking at the role of undergraduate student loans on moving on to graduate school. And what we saw is that for Black and African-American respondents, that undergraduate student loan debt had a greater influence on the likelihood of going on to get a graduate program, a graduate degree. So there's amazing loan repayment programs within the behavioral health workforce field right now, which is amazing, but it could be that for some populations, the loan repayment program that comes in 2 years after your graduate program when you become licensed might be too late into diversifying the workforce from the beginning. And then also thinking about this gap between graduating with your master's degree and then being able to practice independently with your independent license. And so thinking about if there's ways that organizations can support the behavioral health workforce in that 2-year gap, either in an apprenticeship model or building in supervision in order for them to be able to work in the workforce. And then, you know, as we mentioned earlier, is that the behavioral health workforce includes many unlicensed clinicians, as well as individuals who have lived life experiences and serve in roles as peer and peer recovery support specialists. And really trying to think about how can we support folks who are in those roles that is not a requirement of formal education. So we've heard from many folks thinking about wanting to expand their career or advance their career without having to get an advanced degree. Is there ways that we can create a pathway that includes being a peer that is a supervisor or a trainer as a way to advance their own professional career. So when we think about what we can do to support the current and future workforce, thinking outside of the traditional front door, but also thinking about that, there are many ways to get into this field, and there's many ways that you can go once you're in the field, and making sure we're supporting all of that within the workforce.
And we could have really spent the entire webinar talking about sustaining and retaining the current workforce, but that is really a kind of a topic for another day as well. Again, something for us to think about when we're thinking about those career pathways and how do we retain people in the profession before they burn out. So as we get to the end of our presentation, we just wanted to kind of echo again that we have more than one policy lever. And I saw just very quickly in the chat, someone said, hooray, I'm so glad loan repayment is not the only solution. And it's not. So we certainly want to maximize the benefit that students have from loan repayments. These are wonderful things. In fact, among the National Health Service Corps, we know that behavioral health providers are becoming the largest group of folks who are participating in that core. So we have other workforce policies that we can use. So thinking about the reimbursement changes that we mentioned for counselors that are coming down the pike, insurance access, as we mentioned, from Medicaid expansion, for example, and there are still, I believe, 12 states who have held out. So we have other mechanisms to think about. When we think about barriers to practice and to service, we again can think about new modes like which can really help folks. But in the same time, if you have providers who are working remotely, they're not necessarily part of the community. It might be a way to attract folks who speak a different language, but they're not necessarily in the communities that they're serving. So there's a double-edged sword to a lot of this. We talked a little bit about some of the education incentives. And so just thinking about what we're doing to train folks early on in their careers so they get socialized to expect an integrated team-based collaborative model. And that behavioral health is really everyone's kind of purview, not just, the clinical social worker or whatever type of behavioral health, but it is all of the other professions' purview as well. And then thinking about what do we do to sustain that down the road. So how do we create continuing education that is meaningful and robust for people in the workforce? And then we've talked again about local, state, and federal policies. So when we think about federal policies, the removal of the X waiver, for example, that is supposed to be a way to increase access to MOUD. But just thinking about scope of practice laws and thinking about local service delivery, certain states, certain counties are more generous in what they offer than others, and so there's just something to think about this. And our ADI study is kind of an example of that. So we hope that in this very quick 40-50 minute presentation, you'll really get to see that we do have opportunities to advance the behavioral health workforce. We have to do this looking at broad policy levers that really consider reimbursement, payment, and financing. We can't expect this problem to solve itself. You have to invest in it. And unfortunately, the shortage and the crisis that we've seen has really been because of a vast underinvestments well before COVID. When we think about behavioral health care delivery, we need to really think outside of the box. So again, not in clinical walls, not just in primary care or in a community-based mental health center, but how can we provide better access to children in schools? How can we provide this through street harm reduction services? How can we provide this in dental settings, for example? Again, thinking about incentivizing new entrants into the behavioral health workforce, again, perhaps with loan repayment earlier on, or with the benefit of going on if they wanted an advanced degree, but then thinking about incentivizing those in the field. And what we do for our behavioral health clinicians in the field is we expect them to supervise and to mentor behavioral health students for free, and sometimes just out of the benefit of just being a volunteer, and that's not a really sustainable model either, just given the demands on people's clinical work and then what we expect of them in training our behavioral health workforce. And then thinking about tracking data and outcomes. We, again, are so grateful to have the Behavioral Health Workforce Research Center so we can think about these issues. We're never going to be able to look at the 5 A's or think about how we're going to think about workforce shortages if we don't have proper ways of evaluating where are we currently, where do we need to go, and where can we make better improvements. And so these are kind of our 4 takeaways that we hope you'll think about when you're thinking about the behavioral health workforce going forward. We have about 10 minutes for questions, and we've also provided our email addresses. We are in the creation of a website. Our projects are not finished yet, so there's just kind of a teaser about each project, but we hope at the end of the summer, when we finish up all of those projects, there'll be a policy brief and findings to share with you in more detail.
Wonderful. Well, that was a great presentation. And as you may see in the chat, there's an individual asking if you have a newsletter. So they're definitely interested in your content. Just to reiterate, a question that came in earlier via the Q&A was, does your work take into account tele-behavioral health? You mentioned it later on, but the answer to that's pretty much no, correct? They're referring to when you're looking at the ADI, the Area Deprivation Index.
Yes, it unfortunately doesn't include tele-behavioral health, and another limitation of that study is, likely folks go beyond their neighborhood block group to deliver care. I think there's so much for us to learn about how clinicians are engaging with tele-behavioral health care. So what we've been hearing anecdotally is folks will have a primary position that they're filling, maybe at a community health center, maybe at a community-based mental health center, and then on the side are also doing kind of private practice. And so, trying to think more about how tele-behavioral health allows for flexibility, but also how folks have been using it to support their own employment. And so, yeah, we're really curious. There's different workforces that have better state compacts, interstate compacts. So social work actually does not have one, although I think they're working on it right now. And so because of the lack of interstate compacts, particularly for LCSWs, we're unsure if folks are commonly providing behavioral health care across state lines. And when we think about state scope of practice and reimbursement, that will likely be another thing to think about with tele-behavioral health.
All right, thank you. There was also a question that came in the chat during your presentation. It is, how much do you think that the nationally noted inherent bias in the social worker licensing exam impacts the number of BIPOC or minority individuals who enter the workforce? And is there something that can be done to correct this?
Thank you for that question. Lisa, do you want to take it?
Yeah, no, we're really aware of this, and it's something that we're paying close attention to. It's also why we wanted to pitch one of our projects that focuses specifically on the BSW to MSW pathway and why and how we are losing students of color. And then thinking about what we can do from a programmatic standpoint to again, invest in students, not just when they're students through a BWET mechanism, for example, or through their MSW training, but what are we doing to provide them with supervision and licensure support and preparation for the exam in that 2-year gap before they take the licensure test? And so there's very little kind of support and evidence and programmatic efforts before that data came out. And now that it is out, hopefully we'll see some changes, but we're well aware of that. And it was the motivation for one of our projects to really see what we can do to kind of fix that leaky pipeline in social work specifically.
And I'm sure many of you know, like some states are trying to find ways to license social workers that do not require ASWB exam. And, I think the field is in a place where it needs to think critically about how licensure is the test itself is biased towards folks of color and how that is impacting the diversity of the workforce. A lot going on.
All right, thank you. And we do have another question in the Q&A panel, as you may have seen. Do you know of any ongoing work to understand how much effort isn't being spent on training non-physicians, behavioral health providers, how to bill insurance?
This is such a good question, and I don't know. I think I reflect back to my experience as being a graduate MSW student. We did not learn anything about that. And as soon as I started practicing, I realized how much of my practice was dependent on insurance and how many days I worked as a psychiatric social worker working for a partial hospitalization program, and how many days kiddos were able to stay with us were dependent on their insurance type. And I don't think enough. I think when folks are moving into private practice, that's when there becomes more understanding. But I think in the, it's a 2-year program, it's not a ton of time. Lisa probably has a better answer, being a former senior associate dean of the MSW program, but that's I don't know many people working on that. And I think that'd be a really interesting topic.
Yeah, indeed. And I think more students are graduating from master's level programs and going directly into private practice, whereas before the pathway used to be through more, public-based community health organizations or nonprofits. I don't want to derail your question, but another area where we really don't do a good job thinking and training behavioral health providers is on electronic health records and documentation. There are so many ethical conundrums around that, but really just the technical aspect of that. If we're thinking about data and looking at how teams collaborate, how teams work, how are teams effective, if we don't have proper documentation to note that, it's also very difficult and can impact what we know about this field. So I wanted to bring up that documentation piece in addition to the person's question.
All right, wonderful. Well, we're almost at our allotted time. Do you have any, and first of all, this has been a wonderful conversation. Thank you very much again. I mean, there's a lively conversation on the chat too, which we always love to see as well. Do y'all have any final thoughts y'all would like to share?
I don't think so. I'm so excited to see folks in the chat connecting and talking, and I'm so excited that you all have the same temperament to think about beyond workforce shortages, beyond loan repayment, that there are so many things that we can do, and really pushing the field in that direction to understand. So thank you all for being here.
Wonderful. Well, thank you, Brianna, and thank you, Lisa, and thank you everyone in our audience for attending this event this afternoon. Have a good rest of your day. Goodbye.
Thank you, everyone.